It's fun to have a panel of providers of different types, and we work in different settings, and all of us, I'm sure, have debridement in our practices. So it would be interesting to hear about the different forms of debridement that we have and how we make that decision about which debridement method we use.
We do a little bit of everything. We do some bedside sharp, definitely a lot of enzymatic, a little bit of autolytic occasionally.
Being in a wound care center, we do a fair amount of sharp debridement, but you know, these are walking, talking patients. And because we can't completely anesthetize them, we use mostly topicals. That's why we need to have something in between those sharp debridements to continue to do the debridement.
Kind of depends on the patient, but most of the time I feel like if you're going to use this and they need the sharp, you need to use the enzymatic with it, because if you don't have the enzymatic, then it's harder to do the sharp when you come back to see them the next time or at their next visit.
As far as talking about methods of debridement, the first Motley paper had a big impact on the way that we do things, which showed that diabetic foot ulcers that receive sharp debridement plus Santal versus those that receive sharp debridement without Santal, the ones that got the Santal got smaller, faster.
I'm kind of curious, do you start the debridement process, sharp debridement, at their first visit in the outpatient setting?
Many times they'll have some debridement to some extent that first time.
Well, the first principle in time, tissue. So if we leave the necrotic tissue in the wound bed, we're not going to get ourselves where we need to go, and we're setting it up for further infection.
So Jeff, earlier you brought up the Motley study and how it really educated us about the combination of sharp debridement and Santal with diabetic foot ulcers. The second Motley study, where they actually did it as a comparison to silver.
The primary endpoint was the mean % reduction in ulcer area, and there was a clinically relevant difference between the two groups, where those that received sharp debridement plus Santal decreased in size by an average of 62%, whereas those that received the sharp debridement plus silver decreased in size by only an average of about 40%.
I think this kind of goes to the wound bed prep idea though, right? Getting the wound smaller is really what we're trying to do.
Not only in comparing the group that received the Santal versus the group that received the silver did we see that those that received the Santal had a greater decrease in the mean area, but what may have been surprising to some was that the silver group actually had more people that developed infection than did the Santal group.
That was surprising. But I think it goes to what you made such a good point about, is we need to take away the nidus for that bacterial growth, the groceries, if you will, of what the bacteria like to feed on. So getting it clean, getting it clean more efficiently, faster, is certainly going to take that nidus away.
What we found is the cytotoxicity, that it's really lowering our healing rates because we're delaying things even further.
Because we now have clinically relevant silver resistance, which I think is important for clinicians to respect, and it's important that we keep that in mind when we make the decisions about the use of silver.
For us, I think, looking at that paper, one is, really thought about how it affected diabetic foot. And historically, we really haven't used much in the way of silver for diabetic foot. So I think it was a validation of some of our constructs of saying, we're not going to use silver for diabetic foot too much, and what we're doing already is okay.
We hit them with Santal right away because we're doing a sharp debridement at that initial visit almost every single time, and we want to back that up with the enzymatic debridement that Santal offers. And you mentioned the bioburden. Sharp debriefment's great, right? And if we're not working on that necrotic tissue via enzymatic debridement, between our sharp debridements, the food source is there to help it maybe come back faster.
I think a lot of people would have looked at it and said, okay, I would have been fine with the paper if it just said the area gets smaller in this group over silver. I think the added portion of having a large reduction in the number of actual infections kind of made you think, okay, this is definitely not something we need to be doing with silver, and that Santal is an appropriate agent to use in this population.
But the take-home message wasn't that it was an antimicrobial. It was that getting wound bed prep, following that time principle, but getting that wound bed prep done earlier means likely less infections because the bacteria just don't have anything to lunch on.
This really spoke to that concern where 5 people in the Santal group developed infection, whereas 11 in the silver group did. So actually, that should really speak to those that might be holding on despite the resistance that we now know about.
When we're trying to educate people on the importance of getting tissue debrided rapidly, the faster we get wounds cleaned up, the less potential for infection.
With Santyl, it's going to be selective. It's not going to harm your good tissue.
So even with all this discussion of silver that we've had, there will be those that still want to use it. So what about combining different products with Santyl? Some may want to see about maybe using them both together.
Absolutely, yeah. We've all been talking about the Jovanovic paper for so many years, and what's exciting is they've done further testing to look at other compatibilities. So people can go to santyl.com now and get the whole laundry list of what it is that can and cannot be combined. As soon as we're done here, I'm going to look it up on the internet. I'm excited.
Collagenase Santyl ointment 250 units per gram is indicated for debriding chronic dermal ulcers in severely burned areas. A slight transient erythema has been noted occasionally in the surrounding tissue, particularly when collagenase Santyl ointment was not confined to the wound. Therefore, the ointment should be applied carefully within the area of the wound. Safety and effectiveness in pediatric patients have not been established. One case of systemic hypersensitivity has been reported after 1 year of treatment with collagenase and cortisone. Use of Santyl ointment should be stopped when debridement is complete and granulation tissue is well established. See complete prescribing information for more details. This video is intended for healthcare professionals practicing in the U.S. only. It is offered for informational and educational purposes only and is not intended as medical advice. Viewer discretion is advised.